I was able to provide treatment post-evaluation. Treatment consisted of manual therapy, doing a seated mid and upper T-spine thrust, as well as a lumbar sideline neutral gap manipulation on both the left and the right side. As I remember, I was actually able to get her to cavitate with all of the different manipulation techniques. She was able to tolerate the lumbar techniques, but the T-spine techniques, even though I was able to get her to cavitate, she was extremely uncomfortable, almost going completely rigid as I manipulated her T-spine. We did work on some basic core stability exercises, which I included in a packet for her to do as some home exercises before she came in for her next visit. And basically we worked on some simple bridging, quadruped, straight leg raises, and working on some thoracic extension mobility movements in a chair using a towel on the top of the chair. After I had her go through the treatment, we did do some post-treatment reassessment of her range of motion, which was basically unchanged, and just when I asked her how she was feeling after the treatment in terms of making things better or worse, she basically said that there was no change. She felt the same as she did when she walked in. The next time the patient came in, nothing had really changed. She basically reported that she had some less pain bending over to dry her hair, that she had been non-compliant with her home exercises because she was just in too much pain to do them, and she was spending a lot of time on the couch watching TV. She said she was extremely sore in the posterior left rib cage where we had done the manipulation, and she still had some soreness in her low back. This is where things started to get frustrating with this case. Because she was a Department of Defense contractor, she was working through her contracting company as well as workers' comp to coordinate her treatments. And I ended up seeing her for 24 initial treatments. Unfortunately, she had some emergency family issues where she had to leave the area a couple of times and miss treatment. Her husband also returned from Iraq. He's also a defense contractor as well, and so she did some traveling with him. So unfortunately, I was not able to see her as consistently as I liked. As time went on too, because of the breast biopsy that was done, I was not able to do any type of mobilization or manipulation because she was just too uncomfortable to do so. Once she did start to feel better, even doing a T-spine manipulation, she would be in so much pain that it would sometimes bring her to tears. And of course I felt terrible about trying to do that the first one or two times, and she actually was motivated to try it because she wanted to get better to return to work, but she was just not able to tolerate it. The other thing was that T2 complaint in the upper left T-spine or posterior rib cage continued to have that very strange hypersensitivity, and I started to notice some things like watching her warm up on a bike on the UBE. She would not use her left arm unless we reminded her to use her left arm, and I started to feel like maybe this was something that we had to refer her to a pain management doctor for. After the patient had her appointment with the pain management physician, I actually was not able to talk to the physician, but I did talk to the patient's case manager from the company that she works for, who actually is a nurse. She was with the patient during the appointment, and she really was surprised at how hypersensitive she was in the rib cage. The physician that treated her believes that the patient may actually be suffering from chronic regional pain syndrome in the T-spine. This physician had told the nurse case manager that she's actually only seen 2 cases of this in her years of practice, and that she felt like it was fairly rare. The other thing that this physician did was she ordered an MRI. That has not been done yet, and we're still actually waiting for approval from workers' comp. The holdup with workers' comp is that because she was originally diagnosed with a lumbar strain or sprain from her doctor in Houston, they're sort of refusing to do a lot of these things that they don't feel are necessarily related to the original diagnosis. So it's been a little bit difficult to get things done quickly, and I think that's one of the reasons also why I've seen this patient for so many treatments, because workers' comp would just not allow her to see a pain management doctor, and her nurse case manager had to basically convince them that what we were doing was not really helping her that much, and we were seeing some things that we felt were not necessarily something that we could handle at the clinic. Since the patient had the appointment with the pain management physician, I've been able to see her for 2 treatments. Basically, we decided to stick with a graded exercise program where we were continuing to focus on core stability and T-spine mobility exercises. We made the decision that we would basically increase either her volume or intensity little by little, despite any types of symptoms that she was having, especially in the T-spine, since we felt like that was going to be managed by the pain management physician. We also decided for right now that we were going to stop doing mobilization and manipulation, and one of the interesting things was that her photo score actually improved over the course of time where we had not been seeing her too much. Admittedly, she was not doing any exercise. She's gained almost 30 pounds since she's been home from Iraq, just because she hasn't been active and really hasn't been watching her nutrition as well. In terms of her pain management protocol, what that is right now is she was given a cream, and you can see the various medications that are in that cream for pain control. She'll be coming into the clinic most likely once a day to have that cream that's applied, and then we'll be putting on a lidocaine patch over that area on P2, or what is the left posterior rib cage. The other thing that the patient's going to be starting this weekend is she's been prescribed Lyrica. I have a couple of patients that are fibromyalgia patients that are taking Lyrica for the control of chronic pain, and she'll be taking this. There's sort of a step up in dosage as you take this, so it can build up in your bloodstream, so it may take 4 to 6 weeks to really start seeing any changes based on what the Lyrica is supposed to do. On our last appointment for treatment, which was actually Friday, we were able to do a little bit of reassessment. The one thing that I have noticed lately is that even though the patient is still walking at a slower speed, her gait looks more normal than it has been. She's not really exhibiting any forward flexion while she walks, but she still will neglect her left upper extremity with activities. So we're still finding that when she's riding the bike, she won't use her left arm, especially on the UBE. Sometimes if we're watching her do some of her exercises, she'll favor picking up any type of item with her right hand and place it into her left hand, or she may not even pick up any items at all using her left hand unless we remind her. You can see that based on her range of motion measurements at her evaluation versus her latest treatment, they have improved slightly. She still has that P1 complaint, although she says that she feels like it's almost resolved compared to where it was when she first was evaluated. So she's not really reporting P3 at all, and obviously the P2 is the sensitivity, and she still is very sensitive to the touch. So even when I'm applying that cream and that lidocaine patch, she's extremely sensitive. There's a lot of muscle twitching, and she really doesn't enjoy it that much, but she knows that it's sort of necessary to do right now based on what her pain management physician wants her to do. Our plan moving forward with this patient is to continue the pain management treatments, which consist of the prescription Lyrica that the patient will start taking this weekend, the lidocaine patches, and the cream that we've been doing every day. We'll also continue to expose the patient to a graded exercise program which focuses on the core spine stability training for the low back pain, as well as start taking a look at some left-sided upper extremity functional tasks in order to promote normal use, and we just want to make sure that the patient does not continue to neglect that left side. We'll also start taking a look at some of the evidence that's out there in treatment for chronic regional pain syndrome, especially because this patient seems to have a fairly rare case in that it's a thoracic spine involvement and not necessarily a hand or foot like we usually think of with chronic regional pain syndrome. We'll also continue to work with her nurse case manager at her defense contractor, as well as workman's comp, to make sure she gets the appointments that she needs, and we'll also see if we can get her in to get that MRI done of her thoracic spine in the following weeks. So thanks again for your time this afternoon. I apologize for not having a presentation that was a bit more straightforward, but it has been an interesting case for me, as frustrating as it's been.